and click on Go Live.
Okay. Yeah, that's right. I don't know why it was doing it.
There was one step there.
Okay, I think we just gone live now. So do we actually need to go back then?
No. Sometimes it does go back and would have recorded that. So before we proceed, let's check on YouTube and make sure this is live. Can one of the faculties check on YouTube and make sure we are live?
Yeah, we are live. We are live. Yeah.
Yeah, I think we are live. I'm able to see the YouTube.
Okay, wonderful. Does it play from the beginning, Dr. Soma, Ganesh?
No, it's playing from the start, but I think we can, if we want, we can go back. No, it starts from just.
I think we can go back, and I think.
Okay, let's start from the beginning and just a quick introduction again. So, yeah, back to you, Shiv.
Okay.
I think, sir, you need to share the screen regarding the faculty cards as well.
Okay, what I'm going to do is I'm not going to do a full thing. This is okay. Good morning to people in US. Good afternoon to people in UK and the European countries, and a very good evening to people in the eastern part of the world. Today, we are having our first symposium on anesthesia for older people. And incidentally, it is also an International Day of the Older People. And so it's a tribute to them. So this is first of the symposium. And this will be led by Uma Hariharan and Dr. Soma Ganesh. Then we have 2 lectures and then followed by a panel discussion. And this will be followed by a question and answer sessions for, from the anybody who's, put questions on the YouTube or on the Facebook. We will likely go through those questions as well. So the symposium been led by Uma. She's a professor in Department of Critical Care Medicine. She's recently taken over this position at Dr. Ram Manohar Lohia Hospital and Atal Bihari Vajpayee Institute of Medical Sciences, New Delhi. Then we have got Dr. Dhiraj Ail, who will be giving us the first lecture. He's not joining us as face-to-face. Well, it's not a face-to-face, but he's not be joining live. We have his recorded lecture. He's a consultant in anesthesia intensive care at Darren Valley Hospital, Dartford in UK. Then we have Gurunath Murthy joining all the way from Australia. He's a senior consultant anesthetist, and he was head of unit of anesthesia and perioperative medicine at Bunbury Hospital, Adelaide. And he's also director and co-founder of Medicis, which is our, they have made the app for us. The Medicis Gas app is their brainchild. We have Shagun who is a senior consultant at Rajiv Gandhi Cancer Institute of Research Center, Delhi. We have Suchitra, who is a senior consultant, who is a freelance private practitioner from Pune. And then Dr. Soma Ganesh, who is associate professor, Department of Anesthesia and Pain Medicine at Sri Ramchandra Medical College in Chennai. He's one of the other hosts for this session today, along with Uma. And you have Parin, who is assistant professor anesthesia at AIIMS, New Delhi. She'll be one of our panelists for these sessions. And with this, I'm going to hand over to Uma, who will take us through the proceedings for today. Over to you, Uma.
Thank you very much, sir, for your kind introduction. I am indeed indebted to you and Dr. Gurunath Murthy for giving me this opportunity. And I hope I'm able to live up to it. And I would welcome all the panelists, the faculties, and the viewers for this one of its kind symposium, aptly begun on the International Day of Elder Adults. We welcome you all, and I hope you have a great learning experience. We will be beginning our session with a lecture. It's a recorded lecture by Dr. Dhiraj Ail on anesthesia for elder patients. And I would request Dr. Gurunath Murthy to kindly share the screen and make the viewers have the pleasure of seeing the lecture of Dr. Dhiraj.
Before we do that, can we actually ask Soma, because he's a coordinator, another coordinator, any words of wisdom from you, Soma, Ganesh?
Sure.
Yeah, I think it's a great start on an International Day for Older People to have this seminar on anesthesia for older adults. I think we all have shared our wisdoms. I'm equally excited to learn and share from everyone so that we will have a better wisdom on treating our older patients for providing a safe anesthetic care, which is one of the motto for our gas group. I think I request Dr. Gurunath to start the proceedings with the lecture of Dr. Dhiraj Ail.
Wonderful. Thank you very much. I'm just going to share his lecture through a YouTube link. So what can be better than actually having one full bald man, one three-quarters bald, and one half bald in this geriatric session, and three very young, beautiful ladies. So it can't get better than this one today. So just bear with me while I share this, and I hope you can listen to this, and one of the faculties can comment if they are not able to hear this one very well.
Sound.
The audio is not there.
Not audible.
Okay, give me 1 second. Let me go back to Zoom and unmute myself, because previously we did trial this, and let me go back. Okay, am I still sharing my screen?
Yeah.
Yes, we are.
Okay.
Just increase the volume on that. Yeah. Now try playing now. It's still not audible. You're not using headphones or anything like that?
Okay, let me take off my headphones.
Yeah, I think that's the reason. You need to have audio on the thing.
Right.
Yeah. You can play.
1 second. All right. Give me 1 second. Let me start it from the beginning.
Good afternoon or good evening in some parts of the world. My name is Dr. Dhiraj Ail, and I'm here to discuss a little bit about principles of anesthesia in older people. Why have we decided to do it today? Just because it's the International Day for Older People. And I think there won't be any more appropriate time for us to discuss this topic. Now, one of the themes for this year is resilience of the aging population. We are finding that older people are living longer, they're aging a lot better, and they are leading a more. So what are the common procedures we might expect an older people to come from? By far, we know that the human body has not been made to last as long as we are living nowadays. So we do have problems with our bones and our joints. So joint arthroplasties are the common procedures they come from. If you live longer, there's a higher chance that you get cancer. So cancer surgeries are very common among the older people. Fractured neck of femurs is one of the most important and tricky cases you might face as an anesthetist. And of course, there's a variety of urological procedures for which older people come from. The disadvantage of being born as a man is that you're going to have a prostate, and every time you grow older, the prostate's going to give you much more problems. Now, there are certain risk factors which make this patient population very unique. Gradually over the years, we've seen an increasing in elderly trauma patients. They have age-related decreased physiological reserve. So we know that their pulmonary functions are not as what they used to be. We know they have cardiac problems, ischemic heart disease. We know they have CKD, and almost every organ in the body is affected. Because we are living longer, we found that people are having multiple comorbidities. The older you get, the higher your chance of getting cognitive impairment or sensory impairment. Frailty is a realistic problem among the older people. And this thing, polypharmacy, I think this probably is one of the most important things. Because people have multiple comorbidities, they are on multiple medications. And most of this time, you will find that there are multiple interactions, some unrecognized. So polypharmacy contributes to a lot of problem by itself. And older people don't tend to eat as much as we do because of decreased appetite. As you grow older, you also have loss of muscle mass, so you've got decreased albumin, and malnutrition is common in this group of patients. Frailty has been getting more and more recognition as time goes on. And what is important to understand is after we had COVID, frailty has been started to be recognized as a major problem in the elderly. Frailty has been in the past recognized as an independent factor for morbidity and mortality in this age group. This paper actually has found the association of modified frailty index with 13-day surgical readmission. So what do we do in the preoperative stage? And most important thing, I think, which has come or revolutionized our practice on doing surgeries on older people is what we call as an orthogery, or they like to be called as doctors for older people now, or the POPS review, where there is a perioperative or older people service. They look at the patients and they optimize them. Pre-optimization is something we can do before any surgery. Risk assessment is absolutely important. Make sure these patients are not fasted for long, minimal fasting. Prompt surgery. If you are going to go do a surgery, you have pre-assessed them, you fasted them, then make sure you get the surgery done on the day. And avoid of drugs such as benzodiazepines and anticholinergic drugs. If you are in a country which has got what we call as do not resuscitate orders or a treatment escalation plan, or in the UK at present we use what is called as a respect form, please make sure all these are filled in before you go for surgery. However, a caveat to this is that the Association of Anaesthetists in Great Britain and Ireland recommend that if you're actually having a surgery, if you have a DNAR form, then for the duration of surgery, you might need to suspend it, or on the 24 hours following surgery, you might need to suspend it. But follow your local policy, whatever that is. The orthogeriatrician or POPS review is becoming more and more important as days progress. They have been shown to increase the length of stay, significantly reduce complications like delirium, cardiac complications, problems like incontinence, which are recognized quite quickly. They also help in doing things like medication change. If you have not recognized a certain pathology, they're very good at diagnosing cognitive problems. So if a social work referral is needed, they're very good at that. And they generally communicate better than us when it comes to communication with family and carers. They institute measures to prevent delirium, and they aid in better discharge planning. So if you're having a doctor for elder people in your trust or in the hospital you work, we would advise strongly to get a referral from them before you go for at least a major surgery. Pre-optimization, a very buzzword. Yeah, do that in the young. We can do that with patients with cardiac and pulmonary comorbidities. It has its role in the elderly too, because quite a lot of patients who come in for surgery, quite a lot of older patients who come in for surgery have some common themes in them. Many of them are anemic, and correction of anemia is very warranted. Electrolyte disturbances, especially because of polypharmacy, many of the people are on treatment for conditions like hypertension, heart failure. They are on diuretics, and they can have significant electrolyte imbalances. Many of our patients are now on DOACs, things like stroke prevention, or people having atrial fibrillation. They would be on DOACs, and this definitely interferes with a lot of surgery. Many of them have recurrent sepsis, like urinary tract infection. So it's very important to recognize. For example, if you actually have a patient who comes in with a fracture neck of femur, usually we say that these are patients who are medical patients. They have an underlying medical condition, and that is the reason they have been admitted to you in the first place. They might have simple things like urinary tract infection, which might require an antibiotic course for 5 days, and the patient's absolutely all right. But that doesn't mean that you cancel the surgery or postpone the surgery because they are having that urinary tract infection. Most of the times, these have to go hand in hand. Treatment of uncontrolled diabetes. We're having newer antidiabetics, which are coming in. In a recent talk, which we had given on gas, we had said how some of the new agents can have their own complications like euglycemic ketoacidosis, and this is worsened with the duration of fasting. But they also don't eat a lot, so they can have starvation ketosis. Treatment of acute or decompensated heart failure is very, very important because decompensated heart failure by itself is an independent predictor of mortality. They may have tachyarrhythmias or bradyarrhythmias. Some enjoy the tipple a little more than the others, so they might have withdrawal symptoms. The hypertensive and management of hypertension has to be given importance. And one of the things which you have to be very worried about in patients undergoing, especially cemented procedures, is pulmonary hypertension, because having cement and sudden increase in pulmonary pressures are usually not a very good combination. We should risk assess these patients. Just because we can do surgeries doesn't mean we should do surgeries. There's a very interesting patient from Atul Gawande, and it's quite sobering too, because if you actually look at this, they found out that more than 1 million elderly patients who underwent surgery in 2008, 32% underwent a surgery in the last year of life, which means they had the surgery and they died within a year. 18% underwent a surgery in the last month of life, which means that they had the surgery and they died within a month. And 8% of the patient underwent a procedure in the last week of their death. If you actually look at 1,800,000 patients, that means close to 180,000 patients underwent a surgery and did not survive for a week. So we need to be very, very careful when we anesthetize these patients, and we need to stand back and ask a question: is that surgery really essential in those cases? So there are various ways of hip stratification. I mean, if you're having a fracture neck of femur, the commonest thing which we use is what we call as the Nottingham hip score. NELA has come up with what we call as a NELA score, but that's commonly used for laparotomies. I like the score. It's from the American College of Surgeons. You can use it. It's a freely available resource. It's slightly, more extensive. You have to enter a little more data than you would have to use with Nottingham hip score. But that's the reason you come up with a very good risks which are specified in terms of percentages. For example, if I take this patient, what I've entered the details, it says like serious complication, the patient's risk is 44%, and the average risk for someone else would be 12%. So if I talk to my patient, I tell them that you are 4 times higher of getting any serious complication. So if you look at death, it's 3% compared to 45%. So if I were to talk to this patient and I were to explain to them what happened, I would say that in your case, the chance of death is 15 times more than what it would be for a person of your age without your comorbidities. Avoid prolonged fasting. It's very interesting. I was in a Royal College seminar yesterday where we were talking about updates, and one of the updates was about sip till send. I mean, we do practice, or we've tried to institute this at our institution. There's multiple multiple evidence now to say that you can actually have water till you send for the patient. It is not associated with any higher risk of regurgitation. Having or giving a patient small allocates of water, maybe allowing them to sip around 100 ml every hour is quite safe practice. I mean, the people who started this practice almost give 170 ml. But the caveat is you've got to be sure that they are not at risk for aspiration, or they do not have any factors which make regurgitation possible. But fasting or reducing the amount of fasting period in the elderly is especially important, because it can be associated with an increased risk of delirium, as well as people have higher satisfaction if they're allowed to sip water till they go in for surgery. And they do, although there's not much evidence for it as yet, but I'm sure there will be as time comes on, that they have a faster and a better recovery. Post-operative cognitive dysfunction. You got to remember that cognitive impairment is not just a condition, it's a comorbidity, and you got to treat it as that. In the new ASA gradings, we know that any kind of mental illness puts you from an ASA grade 1 to an ASA grade 2. And the problem with cognitive dysfunction is that it is associated with a higher risk of death, an increased length of stay, a poorer functional outcome or delirium, institutionalization, and probably admission to a care facility post-op, and it increases the incidence of refractures probably by falling. And if you actually have got refractures in the prosthesis, which is already there, and you get a periprosthetic fracture, that could be quite dangerous. There is a new nomenclature which is mentioned for post-operative cognitive dysfunction or post-operative delirium. The new proposed nomenclature is perioperative neurocognitive disorder. These are classified as minor or major, and they would have a maximum tenure of 12 months, because after 12 months, you can't call it as a perioperative neurocognitive disorder. You have to come up with some other diagnosis. I'm not going to go into this much more, because I know there's an entire talk which has been planned by Guru to talk about this. And that's the reason I'm not going to talk further about this. But, fast track surgery, monitoring depth of anesthesia, adequate management of pain, that's what it should be written there, and continuous intraoperative analgesia are quite important. This is a very small guideline which we have in our trust for how to manage patients on DOAC. Have a guideline like that for you when you deal with elderly patients who are on DOAC. If you actually have to give anything like neuroaxial blockade, please follow whatever is your local guideline, or there are guidelines from the AAGPI, there are guidelines from Australia as well as America. These are very, very good guidelines. Have a look at them and then go for that. But if you're actually having a patient who is coming with a fractured neck of femur, then postponing the surgery just because the patient's on an anticoagulant is no longer acceptable, because the morbidity and mortality is greatly increased with delay. It is a time-sensitive surgery, and there have been multiple studies which have been showing that if you postpone surgery greater than 36 to 48 hours, your chances of having morbidity and mortality actually grows like the curve which we have, for CO2 and brain. So what are the intraoperative considerations in these patients? Well, the type of anesthesia is absolutely important, or is it? When there's a considerable amount of work going on in the background, whether regional is more useful than general anesthetic in this group of patient. Restricted transfusion triggers are important, because giving people blood exposes them to the risk of multiple problems. So unless they require it, we shouldn't be giving it. Monitoring to the depth of anesthesia. Is there any role of goal-directed therapy? Maintaining homeostasis, prevention of acute kidney injury, and continuous analgesia, including multimodal analgesia and opioid reduction strategies. So let's talk about the first thing, regional versus general anesthetic. I mean, the amount of time people say, oh, I want to give a spinal, that's why I'm going to postpone the surgery because the patient's on anticoagulant or some reason. I think we should stop doing this, because frankly, there's no difference between regional and general anesthesia and the effect on at least 30-day or greater mortality. So there was a large Cochrane review which was done by Gay and Parker, and they looked at anesthesia for hip fracture surgery, especially whether spinal made a difference as compared to the GA, and they concluded that there wasn't much difference. This was another study which was done where they looked at general versus neuroaxial anesthesia and hip fracture, a systemic review and meta-analysis. And in this, if you actually look at this forest plot, there was no influence on the 30-day mortality at all if you either gave a general anesthetic or you gave a regional anesthetic. However, when they looked at length of hospital stay and in-hospital mortality, that means patient dying before the patient was discharged, then of course there was a greater trend of benefit towards regional anesthesia, and there was also a greater trend of benefit towards regional anesthesia when you looked at length of hospital stay. But as I said, overall, on 30-day mortality, it did not make a difference whether you gave a spinal or a general anesthetic. And hence, you can conclude that it really doesn't make a difference if you give a general or regional. I have been practicing anesthesia for more than 20 years, and I probably would have given spinal to less than 5% of my fracture knobs. My choice of a procedure is always a supraglottic airway, giving a general anesthetic with fascia-iliac block. But a lot of my colleagues give spinal, and there's nothing wrong with it. But we just have to move away from this thought that spinal anesthetic is the best form of anesthesia for these patients. Depth of anesthesia monitoring. It has been shown recently that the more deeper you keep patients who are elderly, the worse their outcome is. This was a study which looked at, you gave a spinal anesthetic in the elderly patients who actually have a hip fracture, and then you give them a sedation. So what is the depth of the sedation? So it showed that in patients who actually have multiple comorbidities, we have a system in UK which we call as Charlson's Comorbidity Index, which has got a few specific diagnosis brackets. And if you actually have a Charlson's comorbidity score of greater than 4, then your mortality was reduced significantly, almost by half, in patients who had a light sedation as compared to deep sedation. And if you actually look at it, in patients having a Charlson's comorbidity index of greater than 6, here, 1-year mortality, and this is not just immediate mortality, 1-year mortality in patients in the light sedation group was 28.6 as compared to 52.6. And we know this from a long time, and it's just not, I don't think so it is just applicable to the elderly patient, but the depth of anesthesia, once you start dropping your BIS score to less than 25, that is associated with increased morbidity and probably mortality in some group of patients. So this graph, again, is from the same study. It shows light sedation and deep sedation here. So this is deep sedation, this is the light sedation. So if you look at patients who have got a Charlson's comorbidity index of greater than 4, you will see that patients with deeper sedation do worse than patients with light sedation. So what do we use? How do we monitor the depth of anesthesia? Does using BIS make any difference, or does it prevent delirium? This was a very small systemic review, just having 2 studies which was done. But the thing to notice here is that both the studies showed that there was a favor towards BIS-guided depth of anesthesia monitoring and a reduction of delirium in the elderly population. So I think going forward, maybe this is something which we need to consider. Now, we know that perioperative hypotension is associated with an increase in post-operative morbidity and mortality, but the appropriate management strategy for this remains uncertain. So this was a study which was done where they actually had an individualized management strategy based on each patient. So they either treated the patient for a drop in their blood pressure of around 10% from their reference value, which is patient's resting systolic blood pressure, or they went ahead with the strategy of giving, allowing the blood pressure to drop below 80 and then treating. So in the first group, they used noradrenaline to treat the patients, as well as in the second group, but they were treated only if their systolic blood pressure dropped to less than 80. And the results of this trial was quite shocking. And if you look at the probability of post-operative organ dysfunction, okay, you found that in the group which were individualized treatment was much, much lower than the group which had standard treatment, which made the authors conclude that, amongst patients who predominantly are undergoing abdominal surgery, this was an abdominal surgery, who are at an increased risk of post-operative organ dysfunction, especially renal dysfunction, cardiac dysfunction, just making sure an individual systolic blood pressure management resulted in better outcomes and lesser organ damage. Now, we know the elderly patients run themselves dry, but what do we do with these patients? Do we give them more fluid or not more fluid? It is quite difficult, not just in the elderly, but even in the younger population. And this was a very big study called as Relief Trial, where they randomized 3,000 patients to either liberal or restrictive fluid strategies intraoperatively and 24 hours later. And this is what they found. They found that there was no improvement in mortality and hospital stay. There was an increased incidence of AKI and surgical site infection in the restrictive group. They said that it's probably better to use a zero balance rather than a restrictive approach. Use of goal-directed therapy in theaters has increased ever since the enhanced recovery practices started taking place in our theaters. And is this something which we should be using in the elderly? My frank opinion is yes. This was a study which was called as the Fedora trial. In this study, the aim was to actually evaluate post-operative complications in patients having major elective surgery. They used the esophageal Doppler. They used goal-directed hemodynamic therapy, in which the administration of either fluids, inotropes, or vasopressors were guided by stroke volume, mean arterial pressure, and the cardiac index. The esophageal Doppler monitored goal-directed therapy, they found reduced post-operative complication, it reduced the hospital length of stay, but this was in low to moderate risk patient, and this was in patients who were undergoing intermediate risk surgery. But they found no difference in mortality. And hopefully this group of patients, you would not expect the mortality to be very high, but certainly in major surgeries, it has been shown to be of benefit. So if you have a cardiac output monitor, either an esophageal Doppler, or you have got something, different like thermodilution technique, or if you have a Pico, Lidco, or what we call as the Edwards monitor, please do tend to use them for high-risk surgeries in the elderly. This was another study which was called as the HIP-UP study, where they actually found whether using goal-directed therapy was beneficial in patients having hip arthroplasties. And they found that using goal-directed therapy in hip arthroplasties reduced post-operative complication. They also caused a reduction in post-operative bleeding, as well as hospital stay and ITU. This is a very simple graph, which actually shows you about the length of hospital stay after surgery. And you can see this is the control group and this is the goal-directed group. They have a much narrower length of stay and as compared to the control group, as well as a much, much lower length of stay. So we come on to the post-operative period. I think pain management is probably the most important thing. Some of the elderly patients or the older people which we deal with, they do not have the cognitive ability to ask for pain relief in a timely manner. Most of the time, the delirium is confused as, delirium, when it could just be very simple pain relief, which could sort the problems out. So pain management is very important. Prevention of post-operative delirium, early mobilization and prevention of deep vein thrombosis, very important. Early nutritional support, early rehabilitation, physiotherapy, occupational therapy, what was required for them. Prevention of falls, please do work on this because they do tend to fall, and various strategies to employ decrease or prevention of falls. It can be quite important in the post-operative period. And where possible, geriatric centers or wards are to be there. I'm sorry, so old presentation, we should be calling them older people and not geriatric population anymore. But yeah, so wards for older people or center for older people are something which we can help with. Pain management. I mean, I'm a great fan of IV paracetamol, although it's not considered to be the most sustainable thing nowadays. But I still believe that IV paracetamol has a better profile than oral paracetamol, and I give all my fracture neck of femurs IV paracetamol. You know, we are regional enthusiasts in this group, and regional anesthesia is probably, I think, the most sustainable and most beneficial of all anesthetics. Avoid opioids, especially codeine, cyclizine, and especially tramadol in these patients. They don't tolerate these drugs very, very well. You could use PR and Oromorph as compared to, Oxynorm for breakthrough pain. And avoid NSAIDs, because NSAIDs actually increase the incidence of fragility fractures in patients who have undergone, fracture neck of femur. So it's one thing which I actually absolutely avoid in this patient, plus causes an increased bleeding risk. Very rarely, I know we are going towards opioid-free world, but some patients may require a PCA. You could balance this of giving an opioid or having a patient in pain and delirium post-op. So preventing delirium, I'm not going to go through this because I'm sure Guru has talked to you or is going to talk to you about this, but these are very easy methods which we can use. The treatments are haloperidol, olanzapine, or clonidine, but our haloperidol and olanzapine per se are not great drugs. So I think the strategy should be to prevent delirium rather than to treat delirium. Well, with that, I finished my talk. I'm sorry if that this is a recorded talk and I can't be there for any questions, but we're going to have a Q&A session later on with all the other members. If you have any questions, please ask them. For people who are watching this on my YouTube channel, if you have a problem or if you have a question with anything which I have said, please put it down in the comment section and I will make sure I'll answer that. With that, I end my talk. Thank you very much.
I'm Cynthia Bauer in the Office of the Associate Director for Communication. I coordinate the health literacy and clear communication activities here at the agency. And welcome to.
That was an
back.
Yeah, that was a fantastic talk by Dhiraj. I think the initial talk of Dhiraj was regarding perioperative renal failure in elderly, and I apologize for the changing topic, but I think this topic is very valid for all anesthesiologists, especially postgraduates and trainees, because I think Dhiraj has covered extensively in all aspects about the anesthesia for the older people. It was very fascinating to listen to his talk and all the interesting things. I think if Dhiraj is available, we will get back to him if he can join us for panel discussion if he's free. And I think we can move. We are moving on to Guru's talk. As always, Guru is with his full of wisdom. He will have a fantastic talk on perioperative delirium, post-operative delirium, rather than I think not on post-operative cognitive dysfunction, I guess. Over to you, Guru. I think you will. I think you will take the audience by blast. Over to you.
Well, one of the blasts did happen about this topic a long time ago in Chennai. You were there, very much there. Yeah, look, I think the presentation of Dhiraj was as live as he was there. I mean, even me physically being present here can't do such a beautiful justice, to the way he spoke. And I think he made my life easier. It's almost 11:45 midnight here. I really thank Dr. Uma, Hariharan, Soma, Ganesh, and Dr. Shiv, trying to coordinate people across 3 different continents and 3 different time zones. I'm 5 hours ahead, and Shiv and Dhiraj are 5 hours behind the Indian Standard Time, and still, managed to find, trying to coordinate people across this. And that's the beauty of this global anesthetic society, and we are here for the improvement in safety and quality of our healthcare delivery. Now, when we talk about elderly, it's a complex topic that often we don't want to talk too much about it because, a lot of poorer outcomes are associated with elderly. We know about it. And to some extent, there is a bit of, complacency across a lot of healthcare professionals when it comes to elderly patients, because the acceptance in outcomes is generally, although being poor, is overall better being accepted, and that shouldn't be the case. And we need to strive to achieve better outcomes than what we are currently doing, and it is possible. Now, Dr. Dhiraj covered most of the topics. He did talk about that. I'll be talking about POCD, which is post-operative cognitive dysfunction, which will not be the topic today, which will be more often is a topic on its own. It's almost an hour to more of a topic to discuss. So I'll focus on something called acute cerebral decompensation. Through our time, right from the medical school days, we've been taught about renal failure, cardiac failure, liver failure, everything. But do we ever talk about cerebral decompensation or brain failure? I'm not talking about the brain fade, but it's through cerebral decompensation. So this is a neglected topic right from our undergraduate days. And we're seeing it more often and suddenly realize there is more importance to this. So I'll begin my topic with this picture. Now, this is a kind of a quintessential picture that you would see in rural India and a lot of other parts. Now, what has this picture got to do with the topic of delirium? Because the delirium, the word comes from the Latin word, to stay in a flow track. So basically, to keep these oxes on the track, what does this farmer needs to do? Is to tie them up, to secure them with the big log of wood and beat them up. And that was unfortunately the days where we used to try to keep delirious patient on the bed, stop them moving about, stop them getting out of the bed. And those were pretty inhuman practices. And it was out of despair, out of lack of awareness, after lack of availability of knowledge and skills to deliver the quality care that we can provide to those people who serve their lives to help others. So we've got a responsibility of providing proper care for our elder patients. Now, when we talk about delirium, now it is amazing. Now, this is the same talk I gave in 2018 in Chennai. I went through so much of articles, so much of delirium topics, and you could see that across the world, there are many delirium societies. There's even a delirium awareness day. I even looked up on this. This was about 5 years ago, which had a topic called idelirium.org. And you could be a delirium superhero. So why so much of investment of time and energy in delirium? I also looked up on the posters. This was just before the Chennai, our TACON process, and the Chennai TACON happened in Chennai. Of course, and it appears that even the posters were based in Tamil. So it was just a pure coincidence at that point of time. But this website has changed now, and it has become more of a American Delirium Society. And this website has got more modernized. There is more information that what we can do towards delirium. Now we need to commit, we need to identify, we need to get engaged, and we need to listen to the stories. All right, we need to find teams. You can also identify that surgery and older age is one of the most important aspects in delirium impact. And this is an unfortunate statement that there are no medication approved. And as you can see, it affects 50% of the surgical patients and 75% of the ICU patients. Today, we are not going into intensive care. We've got a lot of experts here, and we'll talk about it. It's another topic. We also get into the aspect of the Australasian, because I do currently work and practice in Australia, and I went through this website and having discussed with quite a few people. Now, you can see delirium has got significant effect, and I would like to go through this as a case that I experienced. And this has enlightened myself and has helped me to enlighten a lot of other colleagues. So I had an 84-year-old female who had chronic mild asthma, trigeminal neuralgia, which was well controlled, and she was generally hypertensive, which was well controlled. She was posted for laparoscopic assisted vaginal hysterectomy through V nodes, anterior posterior repair, sacrospinous fixation, cystoscopy. The general plan was general anesthetic, opioids with multimodal analgesia. It was pretty good, block standard anesthetic, beautiful outcome. As soon as I saw the patient in recovery, absolutely no pain, and patient left recovery with no opioid analgesic smile. We are all so happy. But then day one, she was feeling a bit detached to the world. But, family were present. They were little concerned, but nothing significant. They kept saying that, she's fine. There's no pain. She's comfortable. Let's not disturb her. Now, day two was coincidentally the same day I was doing another list with the same surgeon in the same hospital. And the surgeon got a call from the ward that this patient is quite drowsy, open size, but very poorly responding. Now, something was going wrong. We didn't know what's going on. Something could be, there are some red flags here going on. I'll come to this later. So overall, we need to understand these three different categories, because we often get confused while we talk about post-operative delirium. Now, clearly, there are three categories: the emergence delirium, the post-operative delirium, and post-operative cognitive dysfunction and dementia. Now, you have to remember throughout my talk, and whenever we say POD or post-operative delirium, it is after day one. It's an interval delirium. Often can happen with the patients who had smooth emergence and a lucid period. All right. So as compared to emergence delirium, which happens in recovery, which is very quick in onset. Now, this is even more interesting, that when you look at the actual classification and the description of delirium, you have to look at these four aspects: the attention, the awareness, any additional disturbances, and the onset. Now, it's very important that you look at these four things and then look at a very important thing, as we often think that delirium is somebody who is mad as a hatter, is somebody is going crazy, who is acting very weirdly aggressive and going crazy all over the field. But when you look at this, there are actually three different types. There is hyperactive delirium, there is hypoactive delirium, and a mixed motor type of delirium. And you will not believe that 50% or more are hypoactive delirium that can mimic depression, or just a post-operative depressive phase, or just something that, somebody is going through in a post-operative phase that, just leave them alone. She or he would like to just want to quiet. It's an elderly patient. We don't want to disturb them, but there is significant consequences that are associated with each of these types. So remember, when we talk about delirium, the most common type of delirium is a hypoactive delirium, is often confused with other problems like depression or just old age, right? So, and also another most important thing to remember is this hypoactive delirium, which is often associated with greater mortality, greater length of stay, and worse quality of life. Now, I'll just quickly go through this emergence delirium. Now, emergence delirium is something that happens in immediate post-operative phase. It is common in pediatric population, can affect 1 in 5 adult patients. It is often more hyperactive, right? And is often associated with patients who are on benzodiazepines, who are addicted to smoking and drinking, prolonged surgeries under general anesthetic, generally more associated with inhalational anesthesia, or if there is inadequate analgesia. Now remember that inadequate analgesia intraoperatively can result in emergence delirium. Also, there is a thin line between this and giving too much of opioids intraoperatively that you may cause hyperalgesia or tolerance. So it's a thin balance. So make sure an adequate analgesia is maintained. Of course, tubes and lines, urologic surgeries, or gastrointestinal surgeries associated with nasogastric tubes can affect. Overall, it's been shown that use of opioids, ketamine, and alpha-2 agonists like clonidine, or everybody's favorites nowadays is the dexmedetomidine, may decrease the incidence of emergence delirium. All right. Let's focus on post-operative delirium. Significant consequences are associated with it. Unfortunately, this is a lot less known because we as anesthetists, we are off the hook the moment the patient reaches recovery, or often patient leaves the recovery. But post-operative delirium that can happen a day after the surgery is associated with significant mortality, morbidity, increased hospital readmission, and prolonged admission, and significant cost to the whole healthcare system, up to $150 billion in the United States. Now you can imagine why there are so many societies. Now, this is an Australian study which identified the significant impact, economic impact of delirium. You can see here, they have split the cost involved with dementia and delirium. Now, why we are talking about healthcare in particular, as you can see, delirium is associated with significant healthcare system cost in developed nations, right? Compared to dementia. Dementia is more associated with loss of well-being cost, productivity cost to minimum, but the healthcare cost of comparison of dementia versus delirium is quite significant. Now, the pathogenesis is complex, and it is so complex that even the Delirium Society, American Delirium Society, have not even come to a complete conclusion, but there are a lot of studies suggesting that there is deranged neurotransmission, maybe excessive anticholinergic in the central neuraxial systems, or probably some neuroinflammation. How do we approach this? Now, one of the best ways to approach is identifying the predisposing and precipitating factors. Combine that with surgery and anesthesia and identify how we can make progress towards delirium. There are significant risk factors here, whether it's reduced pre-existing or predisposing, reduced cognitive disorders like pre-existing dementia, frailty, alcohol usage, malnutrition, dehydration, and anemia. And there could be some precipitating factors. If somebody comes with a fracture, there could be pain, there could be hypoxemia, there could be electrolyte imbalance, there could be dehydration from prolonged fasting, there could be medications or their withdrawal. There could be a lot of elderly patients who are on benzodiazepines, and sudden withdrawal can actually lead to opposite effects. People often get in a lot of indwelling catheters in the bladder, and that itself can be quite bad. There could be infection and, of course, surgical stress and blood loss. Let's identify some of the risk factors which can affect then you can have some kind of a predictive modeling in your mind going on. And of course, Dhiraj produced some beautiful predictive modeling. But a lot of the time we are acting with our mind. We don't have an AI in our brain. We need to use our brain to continuously predict. So if there is any patients with pre-existing cognitive impairments, chronic smokers who are still dependent, male gender, if they've got pre-existing sensory impairment, whether deafness or vision issues, advanced age, high SA score, or those who have been living in nursing homes. Patient risk factors, each one is associated with this considerable odds ratio, up to 3 to 4 times. You need to identify all these risk factors in the preoperative stage. Couple of charts that I had from 2018. You can see here 2 charts next to each other, both patients having mechanical fall and coming for fracture hip, neck or femur fracture, quintessential fracture in elderly, and you would be seeing in your everyday basis, right? But on the left side, you got somebody who's got AF, who's got pancreatic cancer, who has had chemotherapy, quite elderly, 85-year-old, but excuse my handwriting, okay? So who had a mental score of 10 out of 10. So the cognition was pretty good. On the other hand, I had on this patient on the right side who had temporal lobe meningioma excision done in the past, who has got dementia and macular degeneration, that is vision issues, and also being on temazepam. So in a quick glance, you can identify patients who are at risk of dementia quite clearly, despite their age. Now, of course, we live in the world of Bollywood and Hollywood, right? And not every elderly patient are risk of dementia or post-operative delirium. So I just love to use this example. And, if you kind of expect this patient coming to you for you to deliver anesthetic, don't be afraid, because they've got great physical reserve and great mental reserve. Some can be dangerous if you don't provide quality anesthesia. So I'm not giving any threatening signs here. It's just an indication of the physical and mental reserve. And lastly, to say, not all bald men are old, are geriatric, or at risk of post-operative delirium. Also, thanks to our Bollywood, Collywood, Sandalwood, all these woods have been useful to spread the message about pre-existing dementias, how we need to care these patients, and remember, nowadays you will get patients and their relatives who have kind of this awareness about pre-existing dementia, which can significantly affect their outcome with the increased risk of post-operative delirium. So we looked into predisposing and precipitating factors. Then we'll look into surgery and anesthesia. There are particular types of surgeries that are associated with very high incidence. And as you can see in this chart, the hip fracture is associated with the highest incidence of post-operative delirium. I'll not talk about intensive care. It is a different ball game altogether, and it will take another whole day. It's very high risk state there. And greater the risk of surgery and different types of surgery, there is a greater risk of post-operative delirium. What about anesthesia? I think Dr. Dhiraj Ail has covered this very beautifully, with much more greater evidence description there. I would say that there is no significant effect of regional anesthesia only in some particular types of surgeries, unless you're not giving no sedation, absolutely no sedation at all. For me, in terms of procedural comfort of doing either the spinal or the regional anesthetic, or intrasurgical patient comfort is very important. So often it is general anesthetic with a nerve block. We'll come about that discussion later on. The influence of BIS has already been explained by Dr. Dhiraj again. He's made my life easier. Perioperative medications, again, be careful with the use of opioids or any major hypnotic agents, including benzodiazepine or long-acting opioids. So just be cautious that opioids, hypnotics can be very dangerous. Either if the patient is on pre-existing benzodiazepine, don't abruptly stop them. But if they are not on any such thing, try to avoid any kind of benzodiazepines. Try to maintain the blood pressure. Again, Dr. Dhiraj has alluded to this topic, and use of any degree of gadgets that are available to you in your setting to maintain the hemodynamics, hydration, and analgesia to the best possible. So it doesn't matter what type of anesthesia you provide. What is important is you try to reduce the amount of opioids, you maintain good hydration right from preoperative phase to intraoperative phase and the postoperative phase, maintain the hemodynamics. The thermoregulation is important to maintain, and that can affect every organ in the body. And there is no evidence to provide any prophylactic antipsychotic. So providing haloperidol or droperidol just because somebody is elderly or at very high risk. I generally have a higher tendency to use droperidol, which is a good antiemetic. So along with dexamethasone, my normal choice of use of anti-nausea medication is droperidol. So I use it cautiously in the elderly with increased risk of QT interval prolongation. So anywhere above more than 70 years, I use 0.25 milligram, maximum up to 0.5 milligram, maximum 3 times daily. So in a way, it kind of counterbalances, may or may not. This is not, this is purely my personal evidence. Now, having looked at the predisposing precipitating factors, the surgical risk factors, the anesthetic risk factors, how do we evaluate a patient with delirium? Now, it could be, as I explained earlier, baseline depression, hypoactive delirium. It could be psychosis, conversion disorders, or it could be just an exaggeration of the dementia. There are different tools, CAM ICU, 480, multiple tools are available. Now use that you are convenient so that you can teach it to 10 other people or the nurses, because it is them who are going to look after the patient and identify these patients. So there are, you can make it as complex as you want or as simple as you want. So this is one of the common tools used in one of the small hospitals that I go to work in. The 482. It's very simple, quick, easy to do it. This is done by a preoperative nurse in the pre-admission area. So they quickly put a score and I get a rough idea what is the risk of post-operative delirium. And then the same tool will be used post-operatively, repeatedly, to identify the risk and the probable progression towards post-operative delirium. It is very simple. Alertness, you can look it up on Google, the 480 tool. You look at the mental status, you use the mental test using some simple tools, age, date of birth, place, and make it as local as possible in their own language. You look at their attention. There are different ways based on the education level, the language, things that is commonly used. Use your own ways. And also the most important bit for delirium is there is an acute change, yes or no. Use this scoring system, and the score is from 0 to 12. 4 or more is diagnostic of kind of helpful in diagnosis of delirium. But even a score of 0 does not exclude it, but you will need a more detailed test. But on a day-to-day basis, in a small setup, in even kind of every kind of a nursing graduate and undergraduate can perform this scoring system. It can be done in ED, it can be done in ICU, it could be done in patient's home, it could be done repeatedly over a period of time so that you can see the progress of the disease and you can use it in recovery. So it's a very useful tool, and that's quite commonly used. Let's follow, then go on to evaluation. Now there are complex mnemonics. We all love mnemonics, and I use this mnemonic downloaded from the internet, and for me, it seemed very complex. Every time I see a patient, there are 10 other things going on. I'm worried about the previous patient, the next patient, the current patient. the anesthetic bit, the analgesia bit, the infection, everything. So in this, how am I going to evaluate this patient and how do I progress and make quick decisions? Is you can use this mnemonic, or then I ask Siri. Siri is very famous. So all those iOS users will know, hey Siri, then I used, sorry, my phone went off on Hi Siri. It went up and turned on. So I used this Hi Siri thing. And it is a mnemonic that I personally developed to my own regular day practice. So obtain complete history and physical examination, identify the risk factors, use 480 in the preoperative phase, identify if there is any substance abuse, do some investigation, including infection, review patient medications, and do imaging to rule out organic causes. So now that you are here, you have evaluated. So we started from predisposing precipitating factors. We identified the surgical risk. We identified the anesthetic techniques or risks, and we have evaluated using either iWatch Death or Hi Siri. Then you identify whether it's organic or no organic cause. Again, my favorite, coming to mnemonic, I kind of use it for my own practice because I developed. Each one of you can develop your own mnemonics. And if you ask Dr. Shiv Kumar Singh, he will develop a mnemonic in next few seconds. So I use this. I'm cross it. I'm cross it means I'm angry with it. I'm not happy with it, kind of thing, right? So quintessential thing is involve a geriatrician. In my current practice, in where I practice in a resource-rich environment, this is very useful and takes a lot of burden off my shoulder. Okay. Monitor twice daily with validated tools. The 480 tool is what I use it and what I suggest everyone to use it, and it's available everywhere. Correct any lab abnormalities, review the medication, very important. Check for their orientation and mobility. Again, Dr. Dhiraj has gone through all these aspects, sleep enhancements. I tell a lot of patients, as soon as I identify that they are at risk, I invite the family members. I tell them, because when we give a general anesthetic or any kind of sedation, their sleep-awake sleep cycle is altered. So I do tell them, please do come into the hospital, get engaged with them, make sure that they do not kind of sleep through the day so that they kind of go crazy in that night or at risk of dementia or delirium. Sensory improvement, if they're wearing any hearing aids or visual aids, make sure they're having that. Make sure infection control measures are in place in the first place, and identify and treat the infections and use some therapeutic measures. And the reason the therapeutic measures are at the end is because it is the least effective measure. Now, when you review medications, you can use this again, the AGSBS criteria, and all these class of drugs are very important to be looked around. Steroids, the opioids, the sedatives, and polypharmacy, every drug has a potential interaction. So go through every medications, use internet, identify the potential interactions, and minimize polypharmacy. Now, as I said, the therapeutic measures are unfortunately of low value, but you may still need to do it if they are on the aggressive side of the delirium. Definitely, you may reflexly find, a knee-jerk situation of using benzodiazepines. So definitely no. Use antipsychotics. Dhiraj did mention of haloperidol, droperidol, or any olanzapine. Wafers are available. Role of prophylaxis is questionable. I do use it. Again, alpha-2 agonist, maybe ketamine intraoperative use may be beneficial. So going back to my case in that elderly patient, I went through the same thing. What I have been practicing, this is the mnemonic that I developed 6 years ago prior to the attack on 2018. So history. So GCS was 10 out of 15, reflex, plantar reflex. Look, I'm not a neurologist. I'm not perfect in establishing a quick, neurological examination, but I knew something was not right. Substance abuse, she used to drink occasional glass of wine per week. It is not terrible. Investigation, everything, but the sodium came out as 126. I did catch, but I didn't stop it there. I went through other bits. I reviewed the medication. We did quickly arrange for a CT scan, rule out stroke, which was negative. So we knew the culprit. We knew it was hyponatremia. Also looked into the chart that she was on temazepam. So I was concerned whether it was stopped or not, and we need, that she's going into a different phase. Now, this was hot off the press about 5 years ago. And again, this is my talk from 2018. Whether it still holds good or not, evidence is still catching up. This talks more about post-operative cognitive dysfunction. There was some evidence of benefit of ketamine in the use of post-operative delirium also. May offer some protection, okay? Now, whether POD, that is post-operative delirium, is just another side of a post-operative cognitive. Can it lead to post-operative cognitive dysfunction? That is still entirely questionable. There is some evidence to say it can potentially. Overall, I can say that, emergence delirium, post-operative delirium, and post-operative cognitive dysfunction are three different entities. Let's not mix it up. Time and again, I've been seeing in our Facebook posts that a lot of people call emergence delirium as post-operative delirium. If you are involved in post-operative delirium, it is after day one. All right. Often emergence delirium does not lead to long-term sequelae. Okay. And it is hyperactive is more common, but whereas in post-operative delirium, it is the hypoactive form, and that is more dangerous. That is more affected with poorer outcomes. Use educational program, increase awareness. It is a multidisciplinary approach and multi-common. It takes a lot of time and patience to put in efforts to reduce the incidence of post-operative delirium. Trust me, there is significant economical benefit to the system. There is a lot of intangible benefits, but you as a doctor with your oath towards healthcare, I think you will be doing justice. So you can use different forms of mnemonics. I've got all these things that I use, high Siri and cross-edit. You can use it from predisposing factors to precipitating factors to up till kind of evaluation and treatment aspect. This is another heart of the experience, not just of the press. This was just a very recent patient posted for HOLEP, which is laser guided prostate resection. They do the laser resection for huge prostate, and then they kind of churn it out and bring it out in a roughly around 2-hour procedure without significant effects of glycine toxicity because they use saline. Now, this was a very interesting case that I wanted to present here because this patient had a total knee replacement under regional anesthesia, some sedation, had post-op delirium. The patient wife was a nurse who came in the preoperative phase. Me and my registrar met with the patient, spoke to the patient and his wife. So interestingly, this happened on day one. Patient went on the hyperactive side, which was not good. The overall experience was not good and they wanted to do something. But as you can see in the medication chart now, I can apologize for the handwriting of my registrar. Patient was on oxazepam daily, right? He had an indwelling catheter, and previously it was the opioids which was blamed to cause hallucination. He was an ex-smoker, but nothing other significance apart from being a little bit obese, and he refused. So I used my usual technique. I'm cross-eyed. I involved a geriatrician very early. So my registrar went up and called the geriatric registrar and said, look, we got this patient. They're coming to you. Because this patient was seen on the day of surgery, we didn't have enough time for all this assessment. So if you have time, we've seen this patient in advance, make sure you get them involved. So we started pre-op using 480 tool. We looked at all the lab tests. Everything was normal, but we did anticipate a high post-operative risk of electrolyte imbalances. We were worried about oxazepam. We were worried about post-operative opioid consumption. This surgery is not generally associated with high risk of opioid consumption post-operatively, but we were concerned, but we are more worried about the indwelling catheter. Okay. His orientation and mobility were fine. There were no sensory issues at all. I got his wife involved and his kids involved to explain to about how the family can be involved in reducing the chance to maintain that thing. We maintained the standard prophylaxis for infection control, and we discussed the option. Now, patient did prefer general anesthetic, so we thought about using drugs like Dexmed, a little bit of ketamine, and to minimize the opioids. So this is the anesthetic chart. I won't go in detail through this. As you can see, the hemodynamics was pretty much made apart from at the induction of anesthetic little drop. And as you can expect, patients who are on AC inhibitors, there is a drop, and we do use a combination of metramidol and ephedrine. But after that initial days, you can see pretty much like a tram-tack anesthetic, and nothing too significant. We use bit of ketamine, bit of opioid, antibiotics were given, oxycodone, just 5 milligram or a 2-hour procedure. We did reverse with sugammadex. We didn't want to use neostigmine and atropine or glycopyrrolate and neostigmine, all those issues that can affect the brain. But I'll go through this quickly. You can see this. We followed up this patient. We got a little bit of recently introduced electronic notes. The patient was fine, but did take off. He tried to run away and he went out, but this was not in the immediate. This was day one, next day. Until next day morning, patient was fine. Absolutely no opioid requirement, behaving perfectly fine, but wakes up early in the morning and tries to get out of the fire escape stairwell. All right. We did everything possible. The patient was again reviewed by the geriatric team, and they are going to follow up. So, as you can see, this was an example where we identified everything. We did our best. Whether doing spinal unknown with absolutely no sedation would have worked or not, I don't know. Often in my population of patients that I see, there is 0.01% chance of patients preferring no sedation at all. So if at all it has to be spinal, it could be with a significant degree of sedation. So I thought there is no difference. So, and that's what patient had previously. At the end of the day, I want to say out to everything. I think I've taken significant time here. Look, we all as an anesthetist, we start to think, what is that I can do? Post-operative delirium, it is something that is post-operative, day one. Look, I do my anesthetic, I take my money, I'm out of here. But that shouldn't be the case. You're a doctor in first place. You can do something. And there are different ways that you can do it. You can increase the awareness. You educate your colleagues. To be honest, even the gynecologist colleague of mine had zero idea about the diagnosis of hypoactive delirium that I could make in her patient, which was day 2 post-op. So it is important. Now, if you teach one, they'll teach two, and it is exponential growth. Now that gynecologist is so much aware, just went and spoke to every possible nurse in the ward. So it has increased such a degree that I'm least worried now, right? It does take the burden off my shoulders too. So in your own practice, keep an eye out, identify the incidents, put in measures, some kind of measures, and see if it makes any difference by doing your own audit. At the end of the day, we are here to provide safe anesthesia for safe surgery and a safe patient, and our duty of care does not end in immediate post-operative care. Think beyond anesthesia and think what you can all achieve. Thank you very much for your time. Appreciate it.
That was a very wonderful lecture,
Oh,
sir. You have covered almost everything, and Dr. Guru and Dr. Dhiraj have almost covered all the topics which may be discussed in the further panel discussion, which is going to come up in the next few minutes. I'm extremely delighted to see this kind of a very well presented topic in many concepts, especially regarding the confusion about emergence delirium, post-operative delirium, and post-operative cognitive dysfunction were cleared by Dr. Guru. Thank you, sir.
thank you very much. Dr. Soma?
Yeah, Guru, it was an, as always, your wisdom brims with, I really wonder you are at night in Australia and giving this talk, because it went as flawless as always, and you had given a very clear-cut plan for how to manage, how to diagnose, evaluate, and manage an perioperative, post-operative delirium. I think even in India, lots of people, I feel even anesthetists will have an lesser idea about the hypoactive delirium. The patients maybe in preoperatively or intraoperatively will have delirium. I have seen quite a few patients, and then I had an discussion with the geriatrician, and around 6-7 years ago, I think I got had an informative talk with the geriatrician and had an evaluation of an hypoactive delirium. She was one of the grandmother of my orthopedician colleague. And then the moment we diagnosed, we initiated haloperidol, and then it was very beautiful. And the one good thing is keeping the circadian rhythm that as you have described always. The circadian rhythm of the patient is fantastically, if it is followed up properly, I think the incidence of delirium goes down a lot. That's from my personal experience that I have felt. And as always, you have rocked it with your talk. I think I'm glad that I have listened to you. I think it's always a learning moment every time I listen to you. Thank you very much, Guru, for this talk. Wonderful one.
Yeah, especially the 480 scores, very easy to follow and very easy to document. It is really nice, and I'm really going to suggest all my team to follow it up in my ICU as well. Let's see.
That's it. I'm done now. It's 11:30 here, so
Okay.
I'm very proud that it even if one person takes it forward, it's worth it for me. Thank you.
Very true, sir. With your permission, can we follow on with the panel discussion?
Yep. Go on.
Yeah. Okay. Sir, now we will be going on to the panel discussion, and we have our esteemed panelists with us. Me and Dr. Soma Ganesh will be moderating and leading the panelists with all the questions one by one. And it is basically going to be on the various perioperative factors which are important in the care of the elder adults. And we will be focusing on various aspects touching upon important topics, especially related to resource-limited settings. So if I can share my screen. Hope my screen is visible.
Yes.
Okay. So this panel discussion on older adults symposium, the panelists are Dr. Gurunath Murthy, Dr. Parin, Dr. Shagun, Dr. Suchitra, and Dr. Dhiraj. And the moderators are Dr. Soma Ganesh, Dr. Uma Hariharan, and Dr. Shiv Kumar Singh. So let's begin. And this is the flyer for our today's symposium. So people who have just joined, today is the International Day of Older People, and this symposium, which is the first of its kind, and many more to come in the series, which we will be having in the days to come. Today, we will be talking about anesthesia for older adults, and my first question is to Dr. Suchitra Nikam. What are the challenges specific to geriatric anesthesia in a resource-limited setting versus a tertiary care center? And what are the reasons to support your viewpoint? Madam, please.
Actually, the answer lies in the question itself. In the resource limited settings, everything is limited. So I would like to divide these into two groups, rough groups, patient related and hospital related problems. In the patient related problems, there is always we can't reach to the patient for the pre-anesthesia checkup. The hospital personnel cannot be very expert in giving us an idea about what challenges we will be facing. So most of the times as a freelancer, we see the patient on the table itself, or just prior to the, we just take to care that we go early for a major case, but there and then itself, we see the patient. So that time we can't suggest that this thing should be done and that. So we have to accept whatever things are on the paper, and we have to go ahead and plan accordingly. In the hospital related, in the group that we have, most important is there will be lacking of infrastructure, maybe lacking, there won't be good workstations, there cannot be monitoring like BIS, or even ETCO2 is not available at most of the places. So, so we have to think our plan of anesthesia accordingly. The expert theater personnel is not available. We are, most of the time we are facing, we are doing the case alone. So if at all we know pre-op that if particular is going to be a risky situation, then we can take care and we can bring someone expert, two anesthetists can do the case and all. But if at all we are facing on the table, we know that such and such is going to be the case, then everything becomes chaos, and then that time we have to decide our anesthesia plan accordingly. So everything is limited, and most important is cost. In resource limited, every surgeon likes an anesthesiologist who works with limited resources, with whatever is available. So we have in the compatibility between the surgeon and anesthetist takes place. So we should know what exactly we are having and what exactly is needed, and accordingly, if we plan, then it's okay. Otherwise, we have to go ahead with it. And other thing is about when we are working in a resource limited place, shifting the patient. For example, if at all, if it is a hip, case of hip, fracture hip, then we have to think that how the patient will go for a, because ECG, the ultrasonography machine or may not be available in the institute itself. So we have to shift the patient for USG, for echo, somewhere else. And for the scanning itself, if we can, so we have to think that, is it possible to shift the patient, or just we have to go ahead with whatever investigations we have. Then also while thinking of a GA or renal anesthesia, we have to, if is blood gases available, if our other sophisticated investigations are available, that all things are to be taken care of in limited resources settings. So as I said earlier, it is the answer lies in the question itself.
Thank you, ma'am, for your extensive answer. In fact, I would truly agree with you that the limitations are not only pre-operative, they can also be intraoperative and post-operative.
Yeah.
And as in the previous lecture on post-operative delirium, there may be limited staff availability in the post-operative period to detect and diagnose the development of delirium, and probably even the treatment may not be initiated at the earliest.
Yeah,
so
and one more thing I would like to say, that there we should understand as an anesthesiologist where to say no, because once you see the patient and if at all you think that this is not possible in that particular situation, then there you should be firm in saying no.
Yes, ma'am, I fully agree with you. Any other faculty would like to comment on this?
Yeah, I think Madam has an excellent experience in freelancing and especially in geriatric patients. So how do you tackle the challenges that specifically you face during while providing anesthesia? So what I thought of some couple of things. One is even if we don't have an arterial line to have in beat-to-beat monitoring of blood pressure, even the pulse oximetry waveform can be utilized to some extent to see the swings and give a fluid bolus so that we can prevent intraoperative hypotension. The other thing is analgesia. even if we don't have an ultrasound, we can put in a landmark guided facial iliac block so that we can take care of good perioperative analgesia. So that's something. So what are the, how do you tackle these challenges? What are the other challenges that you have faced, and how do you tackle these, madam?
Yeah, most of the times, actually, to be frank, I love regional anesthesia. See, old age and minimalism go hand in hand in all modalities of life. Minimalism is the key in old age. So, if with regional anesthesia, we take care of the pain, which the patient is most afraid of the pain while during surgery. So that is taken care of when you give a good regional anesthesia, either central for lower extremity, central neuroaxial block. For nowadays, for the abdominal surgeries also, they are going for this segmental spinal and all. And if at all, if it is GA also, sometimes it is unavoidable. But that time also, if we go for GARA technique, GA plus RA, then it becomes more manageable because it reduces the requirement of the pharmacological drugs which are needed during anesthesia and during the surgery. And it gives overall good results. That's what I think. So whatever the blocks you can utilize to minimize. So we have to minimize the requirements of general the drugs used during general anesthesia. That is the basic principle.
Thank you, madam. Guru, you wanted to ask something?
Yeah, I just got a question. Look, I'm fortunate enough to work currently in a good resource situation. But I can understand a lot of people working in very resource poor situation being there before. But in a kind of your own situation, what would be the most sacrificable things that you would sacrifice? So the thing is, whether you go from bottom to top or top to bottom is the question. So my approach is always, tick everything possible, then try to untick the ones that you can get rid of. So when you come this approach, then you'll come to a situation where you're within your comfort zone. At the same time, the patient safety, the quality is not compromised. So what would be, I can understand it's very individualized based on the person, their experience and the location. But if I would say always, like, whether name 3 or to 5 things that you would not compromise on. That I think we should always make a note for each one of us. From preoperative, intraoperative phase, postoperative. What are those 5 things or 3 things in preoperative, 3 things intraoperative, 3 things post-operative that I will never compromise on?
Preoperative relevant investigations. Relevant investigations is the thing I will never compromise in. Then relevant is important.
What would be relevant? Relevant
to that particular surgery. Relevant to that particular surgery, or that in looking at the comorbidities. For example, if the patient is diabetic, then we have to get the HbA1c and even the sugar levels. There I won't be compromising. It's a very simple thing. And electrolytes. If the patient is, I see that if the patient is frail, then I will go for electrolytes, because that will affect my intraop course of anesthesia. Investigations is the most important thing. X-ray chest is, or that is the an ECG, that cardiac evaluation, respiratory evaluation, and generalized blood investigations. Those 3 things I will be compromising with. Then in the intraop, actually very basic things, a good sort of monitor which can deliver. If at all I'm going to go for a general anesthetic, then I should be able to deliver a good general anesthesia with the help of that machine, and I should be able to monitor at least clinically what is going on. So that will be my basic requirement, to be frank. And actually, I'm from the era where I did not go for ETCO2 any time. And so I may not be requiring that. I know that it is the norm that it is needed nowadays, but for me, it may not be needed unless it is a laparoscopic surgery. So again, it becomes a surgery specific.
Absolutely right, madam. Sir, shall we go on to the next question?
Shiv, sir, you want to comment something?
I think for this question, what Suchitra has said about limited resources, or it's just not remote limited resources, but also it's remote areas where you may not be able to shift the patient to a center where you would want the patient to get the best care, or the patient may not be able to actually afford it. And you have to actually see that when an elderly patient requires a surgery, the whole family is involved for the care. So when they are going from a remote area to a city center, a city kind of care in a hospital, the amount of resources they require, the money they require is huge. So if you are actually able to provide that care in the area near to their home, then you need to provide the best care. And I think what the Dhiraj has talked about, oh, there is no difference between GN and regional anesthesia and the outcome with that, that just says that, okay, you are fine to actually use regional anesthesia for the elderly. It's the outcomes are totally different. The implications of that paper are different for the Western world compared to the our developing countries. The developing countries actually have to take the conclusion as that, yes, we are doing the right thing for these patients. The outcomes are no different. But for the Western world, where they have been thinking, oh, this is better than that, they have all the resources. And the reason why we actually talk, we have to actually think, as Guru's talk actually give very pertinent here. Obviously, it is not just about the post-op delirium, and it is about the patients who actually, elderly patients who are coming to our hospitals. A lot of these patients actually suffer from dementia. And that's why we aren't able to actually, maybe give them spinal anesthesia, because people believe that that is the best thing to do. And that's why we wanted to answer whether general anesthesia is safer, as safe as spinal anesthesia for these patients, where you cannot actually position them for a spinal anesthesia. So you're absolutely right in saying that if you can actually give the spinal anesthesia for the patient, go for it. There is the best thing you can actually do for these patients. But my advice is that one thing which I think everybody has been neglecting in these patients is a post-op analgesia. Okay, you give spinal anesthesia, patient is fine. In the recovery, patient is fine. Well, most of the patient gets shifted to the ward. Actually, a lot of places don't even actually have recovery in remote areas. They're fine, but once the spinal anesthesia wears off, the patient is in agony. And that's why it's very, very important. And that's why I keep stressing it, irrespective of whether you're giving a general anesthesia or giving regional anesthesia, multimodal analgesia should be the norm. So it is GA-RA plus MMA, or it is RA plus MMA. Okay, don't forget that. Don't forget to prescribe appropriate analgesia for that. If you are given spinal anesthesia, you can very well actually also give fascia-iliaca block for these patients for the post-operative analgesia. At least while they start eating and drinking, they'll be fine. And also don't forget that these patients are fasting for a long time. And this was, I think, very nicely mentioned, that the chances of acute kidney injury is pretty high in these patients because they have been fasting, they don't drink enough. The elderly patient, the thirst mechanism is obtended, right? And they're meant to fast it. Sometimes these patients actually wait for days to actually get a surgery done. So don't be, I mean, I've been doing trauma for a very long time. I'm very liberal with my fluids. There is nothing called restrictive fluid therapy in that. And I know Dhiraj talked about the goal-directed therapy. It is out of the thing now. It is not considered. There's no difference between goal-directed therapy and a what you call fluid therapy, which is guided by common sense. Okay. So there is nothing. So you don't actually require sophisticated monitors to actually provide good anesthesia if you use your common sense. I mean, you would know by clinical thing, you can actually look at the patient and like Soma said, or you look at the pulse oximetry trace. I mean, you actually see a swing in it. You know the patient is actually, dry, give them fluids. So there are simple things anybody can do, whether you are in a remote area or you working in the state-of-the-art center. You can still provide a similar kind of care with similar, outcomes.
The only thing goes against general anesthesia in smaller setups is the post-operative care with regional and any regional anesthesia. When the patient is awake, that requires less post-operative nursing care than the patient is under, because most of the times we go after the surgery is done. We are not in the premises, available in the premises. We leave the patient with the nursing staff, which may not be trained. So that time the regional anesthesia becomes more handy if it is possible, it becomes more safe to give regional anesthesia to such patients. And because only thing we have to take care about is the cardiovascular system, if at all it is a central neuraxial block. But other systems, respiratory systems are not to be, they are manageable with central neuraxial block. And most important is the post-operative care. It is not possible with general anesthesia. It may not be possible because the drug is a delayed recovery most of the times because the other comorbidities, the various hepatorenal insufficiency or something. So at that time, then regional becomes safe to follow. And also, if the patient is awake, then the postoperative delirium also becomes less because the patient goes in the familiar environment with his near and dear one around. So for the patient also, it's good. If the patient is under regional anesthesia.
That's why we're saying that's when what we meant is that when you're actually saying limited resources, it's limited by everything. It's limited by the post-op care, the nursing care. It's limited by everything. It's not just that you don't actually have, but also general anesthesia. Again, when you're talking about remote areas, you're also talking or limited resources. You're also talking about drugs you're going to use or anesthesia tech use, which are not the latest. Now, if you are using, say, inhalation agent and people are still using things like ether, halothane, isoflurane, the recovery from them is going to be very slow.
Yes.
And again, we've already clearly mentioned that if the patient is on benzodiazepines, okay, it's fine to use, but do not introduce benzodiazepines. So again, if the patient is actually under spinal anesthesia, you want to give sedation, people are more likely to actually use benzodiazepines because it's cheaper, it's easy available, rather than actually using infusion of propofol.
Yeah, but actually, in my experience, the patient doesn't need any sedation. If at all you take care of the psyche well, and if you just tell that the patient, I'm going to be with you throughout the surgery, then most of the times patient don't need any sedation, to be frank.
Or they because they have not slept because of pain.
Take care
of pain, they just sleep off. So giving unnecessary drugs are not actually required in a lot of these cases. And same thing is with giving a block or a spinal anesthesia or anything like that. Then again, you patients don't require, this is all come from the Western world. They give midazolam and fentanyl for every patient for everything doing a block. I mean, I do deep blocks without anything. Patient tolerated very well. I've not had a single patient who said, "Oh my God, what have you done to me?" types. Okay. So if you can avoid things, do avoid things. And that's again is what the lecture by Guru was, that you don't require to give too many things to a patient. The lesser you use, you're right, Suchitra, be minimalistic with patient. Yeah. Okay, I think let's move on.
Guru, would you like to pitch in to?
Yeah, this question is actually for Dr. Guru only. If an elderly patient is posted for hip surgery, what will you prefer for perioperative care, GA or regional or GARA, and why? And what does the evidence-based medicine say? So, Dr. Guru sir, if you would like to throw some light on this.
No, thank you very much. Look, this topic has been discussed quite extensively,
Yes.
and it's been very controversial also.
Yes.
People do get very passionate about what they love, and they also get very passionate about, to the extent that they cherry pick the evidence. Like, I'm trying to be as unbiased as possible. Okay, so whenever I talk about evidence, so just be mindful that the evidence is only what is available on the internet, and is the evidence that is being produced by the world, which can actually produce the evidence. Okay, so I'm not going to say, if I say evidence, look, for me, the idea of evidence-based medicine is something we need to always take it with pinch of salt. Is always think about how it is applicable in your practice. Now, my own practice is a mix of both public hospital, private hospital, and different resources. There is a little bit of mismatch, but I'm lucky enough to work with good resources. So I was kind of going through, listening to what Dr. Suchitra madam was saying and Dr. Shiv was saying about in resource poor situations. Can you still be able to provide safe and quality anesthesia? That's the only question you have to think about it. Whether it is GA, regional, GA, Garama, Gara, whatever it is it safe in your hands? Is the first question. Now, if I come up and say, and if I say that if I give GA with 3 different types of blocks, and that is the best outcome, and that has got the best evidence analysis, and if somebody is sitting in a research poor situation in a remote location in India or somewhere, and they try to simulate this, can lead to a disaster. Okay, so the question is always, think always what your practice is, how you can do best in your practice. Okay, I'll just do a quick presentation. I'm just going to quickly share the screen now.
Sir, I need to first stop sharing the screen, and then you.
That's okay.
Just a minute.
Yeah, should be.
I have stopped sharing my screen, sir. You can now go.
All right. Look, I've done this few time ago. Okay, it's a very quick presentation, not too detailed. I have to cut and paste from different presentation. Okay, so look, GA versus RA in elderly. Let's assume 2 scenarios. Okay, the scenario I'm talking here is you got the best of everything facilities. Okay, because these evidences are from Western world. Okay, currently I don't know if we have any good evidence coming out from India or in resource poor situations. So please don't extrapolate. Now, Dhiraj also talked about it again. All those evidences will be going through the same things again and again, but you have to look at different outcomes. What is that outcome you are looking at? Are you looking at death? Are you looking at how quickly the patient went out of the hospital? Are you looking at how good was the pain post-operatively? Are you looking at how happy the patient and his family were? Are you looking at, patient was able to eat and drink and happily died or something like that? When I say happily died, it's like, it's an extrapolation of kind of that end. When you talk to Dr. Abhijit Dam, he will explain this more beautifully than I can, is that, the end is inevitable, but is it a nice way to end, kind of thing. So depending on the outcome, often the fracture hip is a nasty thing to happen to any elderly patient. Okay, so let's look at delirium outcome, and there were different various kinds of studies which looked into this. A lot of these, as you can see in this slide, it's an open access. You can look up on this, you can go through the details, and look, we will run out of time going through all those things. Okay, overall, there is no difference from the study that was done across in different states. But again, in your practice, are you worried about delirium? Then don't worry about GA or regional. Okay. Now, are you worried about pain, analgesia, and other outcomes? This is very interesting. This is spinal versus GA. When we talk about GA, there is no regional. So this is just GA with opioids. Okay. So generally, they felt that there was more severe hip pain after spinal, probably because it's kind of a rebound pain. That is, there is, from my perspective, that if you just give spinal, if you see the patient after the spinal wears off, they will have more pain than GA, because with GA you would have given enough long-acting opioids that they sleep through the rest of the day. So in a kind of way, it's a catch, situation that is very hard to explain. But again, be careful about when we talk about these evidences. This was pure spinal, GA, no intrathecal opioids, no kind of GA with long. Then we can look into even more depth, okay, in what other outcomes we can look at. Is there, one of the most controversial topics, that came up in NEJ, everybody across the world who are regional anesthesia enthusiasts, they jumped over this. They talked. There was huge discussion. Yes, this article had a lot of criticisms, but overall, they suggested that that GA was not superior to regional or either way. The reason is you have to understand that if you can provide a general anesthetic in a safe environment, okay, not with a 40-year-old Boyle's apparatus with a halothane bubbling across, right? We're not talking about that, okay? In a center where there is oxygen cylinders, which are very scarce, all right? So we're not talking about those centers. These are centers, if you've got a fully equipped center of a world-class standard of what the developing nations consider, then there is no difference, all right? So then the criticisms were multiple. This article mentioned that older ages, 50 years or older, Dr. Shiv, Dr. Dhiraj and myself are already excluded now, just almost. But out of which 1/4 were 85 years or older. And they also excluded those who had difficulty in ambulating on their own. Their baseline cognitive impairment were lower to previous studies. So you start off with people who had lower cognitive impairment, and then you compare the outcomes. It's a bit dubious. And, they did give significant amount of sedation to those who had spinal anesthetic. And one of the authors did mention that their mortality in this study was lower than they reported in UK. So there were much more criticisms. You can go through the NEJ. What about adding PNBS? Peripheral nerve blocks. This is a very new. This is a very good Cochrane review. I think even Dr. Dhiraj mentioned about it. So definitely, if you're doing spinal or GA, okay, conclusively add a PNB. That is peripheral nerve block. So it reduces the pain, post-operative pain, and also helps with mobilization. And the proportion of pain reduction and duration was directly proportionate to the concentration of the local anesthetic used. So if you're doing a high volume block and if you go down to 0.2% ropivacaine, I'm really worried as against slightly higher concentration with a more focused nerve block. All right. Overall, the peripheral nerve blocks were associated with reduced acute confusional state, my favorite topic. They were associated with chest infections, mortality. Look, let's not go into there. I think some of the anesthetists are too much focused on mortality, benefits of anesthesia and surgery, and it is so much multifactorial. There are so many confounders. I think the lesser we discuss about mortality, better it is. And now PNBs also can reduce the time to first mobilization. So this is quite contrary to what most popular beliefs are. Okay, so this article has very good summary on all these, along with relative risk reductions. So if you are capable to memorize something in the odds ratio of 1:3 or 1:4 or something like that, that is useful to help obtain consent, that is good. Overall, what is my experience? Look, I can only tell you about my experience. It's been all over the place. So I've been up and down, and overall, currently, it is up to patient choice and expectations or relatives if the patients are completely demented. I do understand that there are difficulties in doing spinal anesthetic in a fractured hip, trying to get them into position, provide them analgesia. Now, a lot of people talk about doing nerve block and providing analgesia, then positioning. Sorry, I don't have so much time. Okay. And the theater efficiency, theater outcomes are equally important. And if there is evidence of no difference, then this is all going in the drain. So honestly, and blocks are often done in at the time of admission in the emergency department. So by the time I see the patient and we get into the theater, the blocks would have worn off, and then for me to repeat the block and get into position is another half an hour time. There is a time for the block to cook in, so it's gone. So either it ends up with a heavy dose of sedation with ketamine and opioids, and then trying to position this patient to get enough flexion in lateral position and do the spine. And the failure rate is obviously higher. Okay, from my perspective, yes, it is higher than GA for sure. All right. So again, think about your resource setting, and again, think about what outcomes are you actually looking at. Overall, my experience as Dhiraj, a little bit better than what Dhiraj, or I wouldn't say better. He had about 5% with the regional only. I've got 70% of the patients get GA with regional, with multimodal analgesia, which often includes a small dose of ketamine, small dose of magnesium, about 5 to 10 millimoles, along with dexamethasone, maybe dexmedetomidine if required. And only 30% get regional only with some sedation. Less than 0.001% who get regional. Thank you.
That was a wonderful explanation, Guru. I work in, if I can share my perspective, I work in a tertiary care center. So I have access to all the resources that I can, probably whatever resources that can be needed for the patient. And with my experience, it's sort of exactly the mirror image of you, what Dr. Guru said. It's like 70% I go for regional anesthetics and 30% for general anesthesia. So if we take care of pain very well in the perioperative period and extending into the post-operative period, most of the times, I think most of the problems that the elderly, older adult has is taken care of. And many times in India, patients are surrounded by lots of relatives. So if the relative with one who the geriatric patient is comfortable with is having and keep in touch with them, or usually the spouse, and then the post-operative problems, and this is taken care of. Coming back to GA versus RA, in my experience, I haven't found much of difference with regional anesthesia. In fact, better results for regional anesthesia because the patient is in constant touch with their relatives in the immediate post-operative period. We allow the relatives to come and see the patients in the PACU most of the time. So I specifically, if I anesthetize as an older adult, I specifically make the relative of the older adult to come and see in the patient inside the PACU, so that they will be reassured that everything has gone in. Limited resource setting or not, the expertise or the care given by the anesthesiologist will make a huge difference regarding the outcome when it comes to GA and RA. And I hope and believe that in India, most of the people are regional experts, especially for spinal and epidural, and moving on to blocks as well. So I think the the quality of care that the patient receives in the intraoperative period to prevent complications will be much better, irrespective of GR and RA. The only thing that may lack will be the post-operative pain, and I think people are looking into it as much as often as well. So that's from my point of view. And moving back to this question, the panel discussion, I think the focus is on, again, Suchitra madam for this freelancers anesthesiologist. I think it's question 3, Dr. Uma.
Question 3 has already been covered by Madam in the discussion. So now is the question 4 for Dr. Parin. You can ask.
Yeah, I think that's an interesting topic to Dr. Parin. What is frailty syndrome, and what are the concerns that you have faced in the when you are coming across with this syndrome, and what are the challenges and how you have tackled your challenges? You can please share your clinical pearls accordingly.
Frailty syndrome, it is a clinical state of increased vulnerability with a progressive multi-systemic decline and inability of the patient to tolerate acute stress, as well as increased chances of adverse health outcomes. And one of the most widely used definition is given by Dhiraj Ail, and it has 5 components. One is low grip strength, then slow walking speed, and low physical activity, then self-reported exhaustion, and unintentional weight loss. If a patient meets 3 or 5 of these criteria, a patient is considered frail. Or if 1 or 2 criteria, then it is a pre-frail state. Sir, in my practice, I have come across these patients frequently, those who have hip fractures. And I have given anesthesia to many of these patients. And most of them, as we have discussed till now, have so many comorbidities like neurological problems, Parkinsonism disease, or cardiac problems, and like uncontrolled hypertension, even CHF, or like there are many uncontrolled diabetes. And as we have all discussed, they are on so many medications to control all these comorbidities. So in my experience, like in these type of patients, we and according to the AAGBI guidelines, these type of patients these type of surgeries are semi-emergency surgeries. So we have to optimize the patient as fast as possible, as well as it is very important to get the surgery done as early as possible. So I try to optimize these patients as fast as possible, and multi-specialty involvement, if possible, should be done. Like if involvement of neurologist can improve the outcome. For if the patient is having Parkinsonism, we can involve a neurologist or endocrinologist for a good control of sugar, or cardiologist for good control of CHF. And then my intraoperative concerns are a very meticulous anesthesia planning, and if required, involvement of senior and experienced anesthesiologist if required. And then I prefer in most of these patients regional anesthesia with good monitoring, and then a very good post-operative care where a good monitoring can be provided, like in HDU setup or even in an ICU if the bed is available. If these patients are highly decompensated, even an ICU bed may be required. Yeah.
Thank you, Dr. Parin, for that informative answer. Would any faculty like to comment on this? Okay, so frailty syndrome is basically a very important syndrome to understand in the elder age group patients, because sometimes that may complicate the perioperative course, especially in the post-operative period. And as rightly pointed out by Dr. Parin, the various criteria for diagnosis of the frailty syndrome, and 3 or more of these syndromes need to be present. And there are various dimensions to it, the physical, the psychological, and the social dimensions, which all lead to the development of frailty. And we need to have a multi-pronged approach, both for prevention and management of these, and several nutritional supplements are also known to reduce the development of this condition. So thank you, Dr. Parin, for that answer. Let's move on to the next question. Dr. Soma, would you like to?
Yeah, sure. Before moving on to the next question, Shiv sir, would you like to comment on the frailty syndrome? Because in the West, we see lots of very elderly adults.
Yeah.
So.
Yeah, I think this is one of the very neglected topics in the developing countries. And here in the developing world, we are actually paying a lot more attention to these patients. Now, frailty is part of our pre-op assessment. So any patient, elderly patient is coming for their pre-op check, we do actually have the frailty scoring done for them. And the other thing is there is a lot of stress on something called prehabilitation. So prehabilitation, not only for patients coming for major surgeries, but it is also part of preparing the frail patient. So if you have got time, sometimes we don't actually have time. If they're coming with a fractured hip of surgery, there is not much you can do other than provide good anesthesia for them to intraoperatively, and then take care of that in the post-operative period. And there is, I think one of the main causes is not only the comorbidities these patients have, but I think one is a poor nutrition. And you will be surprised that even in the developed countries, malnutrition in the elderly is very common. You think that malnutrition only happens in the our developing countries, underdeveloped countries, but it is quite common in the elderly. And the reason being that unlike in the our side in India and that kind of Eastern cultures where older parents are looked after by a family, there are a lot of more care. Though this may not be true for in the cosmopolitan cities, but I think I can say that at least 70% of the population in India, they are looked after. They are actually, people make sure that they eat on time. 3 meals are provided to the parents. That doesn't actually happen in the West. You will be surprised that some of these elderly patients will actually only have 1 meal a day. And a lot of time they may not be a nutritionally meal at all. It might be just be something which is already either tinned food or ready prepared meals. But I think we need to be somebody. So I think yes, you can actually get elderly people who are malnourished in the developing countries as well as in our countries. But this is a very, very important thing. This is one of the commonest causes for increased morbidity and mortality in the elderly patient.
Thank you, Shiv sir, for your wonderful inputs. So we move on to the next question for Dr. Shagun. Many elderly patients, they present with preoperative hyponatremia. In our routine preoperative assessments, we find their sodium low. So what is your approach if you come across a patient with preoperative hyponatremia? And do you routinely correct it, or you leave it as such and assess clinically to decide upon it? What could be the possible anesthetic implications in such patients when you come across with preoperative hyponatremia? Dr. Shagun, over to you.
Yeah, actually, sir, that's a very good question. Am I audible to everyone?
Yes, absolutely.
Yeah,
so, right. So first of all, let's define what hyponatremia means. It is serum sodium levels less than 135 milliequivalents per liter. So as per a prospective study in hospitalized patients above 65 years of age, 1/3 of them 33.3% of them had hyponatremia. So why is it so? That's because aging is an independent risk factor for hyponatremia. Aging reduces your GFR. And then these people are on medications like thiazide diuretics, antidepressants, non-steroidal anti-inflammatory drugs. All these reduce the sodium levels, and then there are many comorbidities like diabetes mellitus, malignancy, heart failure, liver diseases, endocrinopathies, like renal diseases, and of course the syndrome of inappropriate antidiuretic hormone. To top it off, there is the tea and toast hyponatremia, which occurs in elderly individuals who follow a diet poor in salt and low in protein, which is very common in India, and these people also tend to drink a large amount of water. So much for the etiology of low sodium. So now I come to your question that should we not take up a patient if the serum sodium is less than 135? No, absolutely not. Because, even in patients with a low sodium concentration, even in asymptomatic elderly individuals, there is increased mortality as well as morbidity. There are gait disturbances, osteoporosis, there are falls, they are more prone to falls and fractures, there is cognitive impairment, longer hospital duration, length of stay. And then as per a study by Leung et al. And JAMA, preoperative hyponatremia is also associated with, a higher risk of 30-day mortality, perioperative major coronary events, also with a higher risk of wound infections, pneumonia. And, the length of stay was increased by 1 day in this particular study. So finally, yes, if the hyponatremia is not severe for most patients, if it's if the sodium levels are above 120 milliequivalents per liter, I do take them up for surgery because most of our surgeries are cancer surgeries and they are emergent in nature. They are time sensitive. Even fracture neck or femur would be time sensitive, and we would not allow a patient, refuse a patient surgery just because the sodium was less than 120 milliequivalents per liter. But we go a step further in elderly patients, and we take them up only if we correct the sodium level to 125 milliequivalents per liter. And if it's acute, if the hyponatremia is acute, and if the sodium levels are around 120 milliequivalents per liter, then we start 3% hypertonic saline, and we correct it till such time the sodium levels reach 125 milliequivalents per liter, and then we take up the patient for surgery. And it's important that this first thing, whether the hyponatremia is acute or chronic. Secondly, what is important is that whether it's euvolumic, hypervolumic, or hypovolumic as well, So, so we do correct severe hyponatremia before surgery. We restore the volume deficit. We give normal saline around 20 ml per kg body weight as a bolus. And if it's an acute hyponatremia, we restrict the free water intake. And if it's severe, then of course we give hypertonic saline, like I said, 1 to 2 ml per kg per hour. But then we do not overdo it, because it may cause spontaneous demyelination, if the rate is if the rate of administering it is high. So loop diuretics may also be given, and we avoid rapid overcorrection, like I said. 0.5 to 1 milliequivalent per hour is to be done, and less than 8 milliequivalent per hour is to be corrected in a span of, say, 24 hours. So I think I've answered that. We do take up these patients if the sodium levels are above 125 milliequivalents per liter. Anything else which you require on this?
Any other faculty, Dr. Guru sir, would you like to comment on this hyponatremia in geriatric population?
That's interesting that you asked me, because you remember the case discussion that I did in my presentation.
Yes.
So interestingly, the patient's daughter was so much interested in hyponatremia, because what happened was look, I, as a doctor, I just kind of help, having some knowledge about all these things, help the surgeon to come to a diagnosis, help the patient to get over this, get better. And then comes the patient's daughter saying that, oh, it's probably anesthetic related. Of course, right? Everything has to happen because of anesthesia. So, yeah, look, I spent nearly 2 hours with zero financial benefit. And I mean, we do calculate every part of our time, you know. But having said that, look, it did give me kind of immense satisfaction that I could explain to the patient's daughter that this hyponatremia was not because of me, not because of anesthesia. And it is something that can happen spontaneously in, as Dr. Shagun was saying, it spontaneously can happen in elderly. You know, I have a family friend here whose elderly grandmother just one day was very down, absolutely down, had to be taken to the ED, and we were all worried what happened. Again, CT had everything, and it was hyponatremia, and she bounced back to normal. And I had to use this example, explain to this patient, spend at least 2 hours for a job that should have been done by the general healthcare community, job that should have been done by the surgeon, and job that should not be my part at all, which I get zero remuneration from, you know. But look, at the end of the day, we need to do what we need to do. And we'll do it if we got the knowledge. And somehow, coincidentally, you know, I happen to know a couple of things. So always, you know, that's all I say, that with hyponatremia, it is so much common, you know. That's why when Dr. Suchitra madam said, like, you know, always remember 3 things that you want to do, absolutely that you will never want to do. And when she said electrolytes, I was so happy. That's all I want to say.
Thank you, sir. Dr. Shiv, would you like to give your expert comments on this?
Expert, I don't know, but yes, I mean, what very, very common. Though we say that the sodium level of 135 and below is hyponatremia, but in most of the elderly, they will actually tolerate sodium well till at least 125. You would actually start getting worried once they reach around 115. Then that's when you will be really, really worried. Commonest cause in the still is drug induced. Okay.
Diuretic.
Absolutely, diuretics are. So the difference between the patients we see and the patient actually you might see in India, the basic difference is that we actually can look at their old records. You know, they all come through the GP, and you can go through and you can actually get a graph of their sodium. So when we actually go on to the electron, everything is electronic with investigations. And you can not only look at the same day sodium, but also you can look at what the sodium levels have been over the years, over the days. If they've been normal and then you find it, then you become very concerned. But if they have been actually on the lower side, then you say, fine, I will take the patient to theater and I will replace some sodium. So instead of actually giving them just, Hartmann's or Plasmolite, you would actually can give them. I would never actually recommend anyone correcting them with hypertonic saline. That again, if you have only one single reading, okay, never ever try to actually do a rapid correction. Just assume that that is a chronic and you need to actually do it a slow correction.
Thank you, sir. I would really appreciate all.
I'd like to add here, Dr.
Yes, Dr. Shagun.
Just one more thing I'd like to add, that hyperglycemia also causes dilutional hyponatremia. So diabetes is very common here, and then serum sodium is lowered by 1.6 millimole every 100 mg% increase in blood glucose above 100 mg%. So that is another common cause which we overlook, diabetic patients with a high blood glucose level do have hyponatremia as well. So, but this is not to that much of an extent. It's not a concern. We can treat it intraoperatively with normal saline also, like Sir just said, with normal saline, with plasma light, with.
Suchitra.
Yeah, Suchitra,
Any
ma'am, you want to
questions
come
in the
in?
YouTube?
Yeah.
This hyponatremia is very, very common because somehow the health is related, the hypertension is related to salt intake. Everyone is hammering that you decrease your salt intake, decrease your salt intake. So
Absolutely.
most of the times it is drastically reduced in our diet, and that's why the patient it's more it is seen more commonly in this particular group. And also in which country we are living. It's a tropical climate. We sweat a lot, and that also creates a lot of hell of difference in the salt diminishing the salt levels in the body. So we have to see in which climate they are living, and then accordingly we should think it should be added or not, like that. That is also one important factor in when we are thinking about hyponatremia.
Absolutely. I think that's a great point. I think one thing I would actually like to say is seasonal variation in the sodium levels in the elderly. That'll be a great project for elderly. Yeah.
I lived in Khandesh. There is extremely hot conditions over there, so that we have to think, right?
Yeah. And I think that's a very good point that I've seen this quite a lot in our families as well. In the elderly, they try to actually reduce the salt, irrespective of looking at that what the weather is or how much they're sweating or what is that. I think just because they are hypertensive and because the doctors say that, oh, you need to reduce salt, what they mean is that your normal salt has to be maintained. Don't take extra salt. That's what it's in, not up and above. Like in India, pickles are common part of the food. So don't have pickles because they have got high sodium level. So, I mean, yes, you're right, but I think if you have elderly relatives or things, and when they actually ask for advice, I tell them they can take normal kind of salt. They don't actually have to have completely saltless food cooked without salt. That's normal salt is allowed. They just that they don't have to have up and above what they normally have. And when we actually have hyponatremia, I just tell them. I tell the nurses in the ward, they say, "Hey, just give them salted crisps or chips. Okay, it's fine. They can actually have the increase in salt, and I just leave them on normal saline." And most of the time,
Yeah, one of the very hilarious thing is that we sometimes put common salt instead of that powder inside the B complex capsules for elderly people to increase their salt content if they are in a position to take it. In the if they are having low salt or low sodium hyponatremia. This was told to me way back when I was doing my MBBS.
Yeah.
Yeah, that's a very good way.
I'd like to add here that my dad is around 80 years of age, and when he's feeling bright, he goes out in the morning to play some golf. So, but the tragedy is when he returns after playing golf, he says, "I'm feeling lethargic now. I'm not feeling all that bright now." And then, but when he takes electrol after that, he feels all.
Yeah. Dr. Soma, would you like to say something, and then we can conclude the session?
No, this question came into my mind because I had a patient with 40 URP, and the patient was about to be deferred because his sodium was 127 or something, and the TURP was through HOLEP. So I told, anyway, in HOLEP, they're going to use saline. So if at all, if some absorption is going to be there, sodium is going to be corrected.
Yeah.
And probably if it's going to be an open or an glycine, if they're going to do a TURP without laser, probably I may think about it. But then with HOLEP, we can go ahead and do the surgery. So this is a common thing that we face in problem, and especially the trainees and senior residents, they will be in a fix whether to correct the sodium and take up for surgery. And so that's why this question came up in my mind. But then I think it was a wonderful discussion. Shiv, you want to comment something?
Yeah, so I think that's a very pertinent question because TRP is a common surgery again in the elderly, and hyponatremia TR syndrome is important. So what you can do is, if I actually have a patient like that, that's my approach is, I actually tend to have a drip in the external jugular from where I can take a venous sample and monitor the sodium into the blood. It gives a lots of information, especially if they're going to actually have a surgery which is going to go beyond 60 minutes, where you're worried. Then just monitor your sodium levels. That's it. That's how you can keep a close eye on the sodium. Don't worry. If the surgeries need to be urgent, it need to be done. Don't just cancel it. It's okay, fine. We will monitor the patient.
Thank you, sir, for your incisive comments.
I think that's the key. The key is anticipation.
Anticipation and monitoring.
Sir, I would request you to give the concluding remarks. We are coming to the close of this first symposium on elder age group patients. Thank you everyone for your patient listening. Shiv sir, please.
Soma and Uma, thank you very much for organizing this symposium, and that too on such a important day. And I think the faculty, Dhiraj, who is not here, he just messaged and said that he was away, and Guru for the lectures, and Suchitra, Parin, and Shagun for being a good panelist. Yeah, and I think thank you. I think to Guru especially, because he's actually on the other end of the world where most of people are asleep, and he's still awake.
No. I'm on a holiday, so that's okay. I'm with the kids. The kids are gone off to sleep. I'm in Gold Coast. Nothing planned tomorrow. Some rides and things like that. So all good. It's a mix of pleasure for me. This was equally pleasureful for me, being with the kids and having fun with the kids, and then doing this activity. Absolutely my pleasure.
I would just, if permitted, I would like to add something.
Sure, ma'am. Sure.
Yeah.
I have actually stopped the streaming.